those that we love or to meet those that we serve in the helping profession, we go out to where they are and we don't judge them for how they live or where they are. So what is harm reduction more generally? We know that it's an approach to working with people who engage in high-risk behaviors, including sex work and substance use, among other things. They are practical public health intervention to reduce the harms of substance use and other behaviors. Non-judgmental services that are provided with compassion, with low barrier, low threshold approach. And by that we mean, let us try to take away as many of the structural barriers in, for example, the assessment process, the intake process, the enrollment process. So how can we reduce the number of questions on a form? How can we reduce the wait time for service? How can we incorporate all of the elements of the assessment, enrollment, or other in the process seamlessly so that people do not walk out before they get the service? And we try to keep the door open. We want people to walk in through the door, and we want people to walk in as often as they can so that they continue to get help. A lot of people ask us, is harm reduction enabling? Why would we offer harm reduction services when we can offer treatment or medical care? And we can offer all of them. They're all part of the continuum that we'll discuss in this talk. I think about harm reduction for many people as a way to get people who have said no or are saying no right now to eventually say yes or maybe. We also know that there are always going to be no's out there. One of the most challenging things in your personal lives, if you are helping or caring for someone who has addiction or dependence, or if you're in the helping professional as a medical provider or behavioral health provider, and you see people who say no to your services over and over, we know that we want to reduce that number of people saying no, but there will always be people that always say no. Those people will haunt us in our personal lives and in our professional lives. And if we don't keep that door open so that they keep walking in even when they say no to get whatever we have to offer that they will say yes to, that may only be a meal, that may only be help washing their feet or getting wound care, but not substance use treatment. We want to keep that door open. Maybe one day they will say yes, but at least we know they're alive and we will work to keep them alive. So why the harm reduction approach? I've already laid out a few reasons, but the additional reasons are that harm reduction reaches many people who would not go for services elsewhere. We reach people that will not come into a traditional medical care setting or behavioral health substance use setting or congregate meal setting or housing setting. And by offering it in a harm reduction facility or with a harm reduction approach that's explicit, we reach people that might not be reached. And we're able to innovate. We're able to offer multiple services. So what does harm reduction, let me make sure, yeah, what does harm reduction look like? It can look like this: medical care on a mobile vehicle in addition to a building. It can look like harm reduction supplies being delivered mobile or in a brick and mortar facility. We do both. It can look like this. It can look like congregate meals for people who are actively using. It can look like brick and mortar housing or other services for people to come in from the cold heat and get respite and ask for help. And how is harm reduction helping people and not enabling people? It is a pathway to services. We know that through in-person interviews and aggregate data from syringe service programs around the country, over 250 programs that the CDC collects and others collect, that new registrants of harm reduction syringe service programs are actually 5 times more likely to enter drug treatment and at least 3 times more likely to not only reduce substance use and injection, but actually discontinue injection compared to people that are naive to syringe service programs, inject anyway outside, getting their supplies elsewhere. We also know that when people come to a syringe service program and harm reduction services, they work with medical staff on site when they're co-located or brought in, and they are actually more likely to engage in primary care, wound care, and that list of medical outcomes of substance use dependence that were talked about earlier, we know that people get treatment for some of those at higher rates than people who don't come to syringe service programs or other harm reduction programs. Harm reduction looks like a pathway in terms of testing and linkage to care. Throughout the country over the last 30 years, we've seen a massive reduction in injection-related HIV transmission, down to 5% in many jurisdictions, including Philadelphia, until the recent 2.5-year spike among people who inject drugs. But we also bring, on the far left, mobile medication-assisted treatment, buprenorphine, to the street through mobile services. So it's a pathway in a number of ways. So we'll talk just briefly about the continuum. Obviously, syringe access and syringe exchange programs, overdose prevention, naloxone distribution, and first response. And when we say that, what we mean is that harm reduction programs, syringe service staff, and volunteers often serve as first responders, much like EMS, police, and fire, in the community by bringing Narcan out and actively reversing overdoses and bringing people in to our shop or others for substance use treatment, among other things. Medication-assisted treatment co-located in an SSP is also possible, as is warm handoff to other MAT programs. Peers in recovery working in harm reduction are the most adept at engaging people into peer-based recovery and medication-assisted treatment programs. Specialty care for people who inject drugs. Again, as discussed earlier, people who use drugs have health conditions that require special attention and special training and a harm reduction approach. They require additional screening techniques and engagement techniques and treatment techniques that happen in harm reduction focused medical care, including co-located in an SSP. Testing and linkage to care, more recently homeless outreach across the country with the coordinated entry push with HUD. A lot of harm reduction programs now are part of the homeless outreach continuum and engage in homeless outreach, finding people who have been out on the street and engaging them into housing care. And then drop-in centers and access points are places to get help, and most importantly, they're brick and mortar structures that people who use drugs can come, be themselves, and get help at their pace. Fentanyl testing, many people are already doing that, and then diversion programs, lead and PAT. So syringe service programs, the kind of linchpin of harm reduction services. We think of the syringe service program as the ground floor entry door, and from there you can just get harm reduction supplies, or you can get everything else. And that includes HIV and hepatitis C testing, MAT, all of the other resources discussed. We know that we can look around the country and see jurisdictions that have started syringe service programs and look at the drops in HIV and hepatitis C infection rates directly related to them. We can also see reductions in skin and soft tissue infections and in hospitalizations for wound care. We also know that syringe service programs reduce STIs and reduce unwanted pregnancy through condom use, condom distribution, other safer sex supplies. We also know that around the country, syringe service programs are some of the largest referral resources for substance use treatment. And many people think of harm reduction and syringe service programs and substance use treatment as two diametrically opposed interventions, but they're not. They're part of the continuum, and they can not only coexist, they can coexist in the same facilities and programs and through partnership. Many of us co-locate not only substance use treatment, but other healthcare on site. We often get asked, I'm part of a regional collaborative that recently asked if syringe service programs were legitimate interventions. They are not only legitimate interventions. As many of you know, the CDC works with jurisdictions to determine their need for harm reduction programming and SSPs. And there is a way to document need based on things like heroin and fentanyl arrests, HIV and hepatitis C infection rates, and other types of health and community markers of need for harm reduction services. There is guidance on how to fund syringe service and other harm reduction programs, with the exclusion of paying for sterile equipment. And there is a guidance around expanding harm reduction. The other big kind of harm reduction intervention that I don't need to spend a lot of time on is overdose prevention and Narcan distribution, since many of you already do that yourselves. We have been doing this since 2006. We have given out tens of thousands of doses of Narcan. Last year, over 15,000 doses of Narcan. Syringe service programs play a critical role because they specifically target people who use drugs and their peers. And what we know from data around the country is that syringe service programs distribute more Narcan largely than almost any other source around the country, other than select jurisdictions where health departments and single county authorities do so at very large scale. And this has been going on for well over a decade. We also know that there is significant research out there that people who use drugs and their peers reverse more overdoses in the field than anyone else after first responders, including EMS, police, and fire. And so the specific secondary Narcan distribution out in the community by syringe service programs to people who use drugs specifically is a critical way of reducing fatality in communities. Medication-assisted treatment is the other key one. And again, many people don't understand how this can coexist, but it can coexist in the same brick and mortar structure and outside on the street. We know that many people are afraid, as you saw from your poll, to engage in substance use treatment or go to traditional assessment facilities. And the harm reduction facility that offers substance use treatment while people are coming for other services, including harm reduction supplies, is a way to engage people that have eloped from the system, that have multiple sign-outs, that have chronic low engagement, or that have had problems in substance use treatment in traditional settings. So this is a key way to engage people, stabilize them, and then ideally refer them to other facilities. We innovate, just like many of you, with same-day induction, with mobile treatment, and even mobile induction. And by including peers in recovery in the harm reduction programming to bring people in the door in the first place, but keep them engaged and model their recovery. So this is a critical way to engage people that have very low treatment outcomes or previously untreated. So one of the things that would like to kind of talk through too, that we were asked to talk through, is how can we help those who struggle? And this includes those of you who love and care for someone who is struggling with addiction or dependence, or have had someone that you've cared for. It also includes those of us in the helping profession, because even though we are professionals, we still come to greatly care for the people that we serve. And we see people struggling every day, including people that don't want help sometimes, and we give them the best help we can to keep them alive. So on the professional setting, I see a new poll. On the professional setting, things that we can do to engage people are looking at what people tell you they need. So you may have someone coming into your facility for medical care, for example, who has 3 chronic medical conditions and a gaping wound. But that individual doesn't see those as problems right now. That is not what they want treated. And we face this fine, delicate balance of offering what we know someone may need based on their medical history or their current engagement, and what they want. And what we do as professionals is try to balance those. We try to get people help they need for what we see as emergent issues that need to be treated, but we also treat what they say they want needed. And we do that for a few reasons. If we work on the medical and behavioral and social and housing, etc., issues that people feel are important to them, whether or not there may be more imminent issues from a provider's perspective, we keep that person engaged. We build a bond. We tell them we care about what they believe they need and they want. And we keep that door open. And when we treat what they need and give them what they need right now, from harm reduction supplies to the medical care they are asking for the one medical condition they are most concerned about, even though there are others, what we do is tell people we care and want them alive, and we keep them coming back for more. And we can say things like, we're going to work on this issue right now because this is what you want us to work on. And this is really important to you. I'd like to get you out of crisis and also work on these. Can we do that? And when we take those types of approaches, we get a lot more yeses than nos or maybes. So we ask people what they're concerned about. What is the most pressing need from their perspective? Anything that motivates people to get care is a way to get them in care, even if it is not the most imminent thing from the provider's perspective. We ask about all substances used. We talk about what those substances do for people. We talk about what they believe the outcomes of that substance use, addiction, and dependence is. We ask about non-traditional wounds or parts of the body that we can screen, because we know that many people, because of shame and fear, do not want to show us their lower legs or their feet or parts of the body that have wounds or brewing infections. We ask people about their psychosocial needs. And again, much like medical care, we will find people that have multiple issues and they don't see them as issues, or that's not what they want to address right now. They want to address something else. That's what we're going to work on. We are going to work on what people ask us to address, but we're also going to bring up those other issues and say, can we also work on this to get you out of crisis? My poll is in the way of my slide advancing arrow. Thank you. So one of the other elements beyond the screening is really asking people what they want in care, and discussing their diagnosis. If they are getting diagnosed, for example, with HIV or hepatitis C or endocarditis or another medical issue or behavioral health issue. We ask them about the fear of treatment. Just in substance use treatment, for example, there's a growing body of literature around the type of withdrawals people have experienced in the past, how the type of withdrawals they have experienced affect their willingness to go into withdrawal and start, for example, buprenorphine or enter treatment. There's a growing literature around traumatic withdrawal experiences and how those affect treatment induction. So it doesn't take away the fear of beginning treatment or medical care or anything else. It doesn't always mean a yes, but talking through that ambivalence, but talking through the fear and really taking very seriously people's experiences in other medical institutions, at access points, in withdrawal, to help them engage in the medical and behavioral health and psychosocial linkage process is critical. We also have to remember fear and stigma. Again, some of the first poll questions, your responses about what keeps people from getting care. The fear and stigma of going into mainstream society or going into an emergency department or going into an assessment center is huge. And we have to remember that I know that many of you are not in areas with large numbers of people living communally in encampments, but many of you do have those, and you do have communal settings. And the openness, the sense of community that people experience when they are marginalized from mainstream society, healthcare, and behavioral health keeps them out of accessing those services. So we have to really take their fear and stigma seriously and address those as we try to broker entry to care. We try to grow the therapeutic relationship, and I always remember, treat anyone I'm working with like my teacher, because people know what they are experiencing. They know what other people are experiencing. They have a lot of information. And we take that seriously, and we respect any assets that people have. We refer for other issues that people present with, and we look for strengths in people. The strengths-based approach is critical. There are people that don't realize they have strengths. There are ways to try to talk through these and always reframe people in terms of their assets and their strengths and the things that they are doing for themselves and for others. We often see people in our professional lives and our personal lives who will bring 10 people into medical care or the syringe service program or substance use treatment, but they're not ready themselves. And that's a strength and asset that we always highlight and always highlight in every therapeutic professional relationship. And looking at empathy. So we want to, ask everyone what they're feeling, what they are doing, what will this diagnosis mean to them, what we are offering them, whether it's PrEP medication, HIV medication, buprenorphine, what is going well and what's not, and why? How can we troubleshoot to improve the treatment process? What do you want today? What do you want moving forward? I get asked sometimes, what is the most critical thing we can do to help people? One of it, besides a harm reduction approach of empathy and low threshold compassionate services, is asking people what they want and always setting goals, small, concrete, incremental goals that people can work on so that they can build self-confidence and self-efficacy. Making it clear that we want to support people. We want to support what they're doing. We are not judging what they are doing. We are repeating back to people what they say they want and how they feel, to show them that we are actively listening and engaging and taking them seriously. And when we don't understand, we ask for clarification in what people feel or what they want in treatment or in services. We want to always express interest and concern. One of the things that we know in the helping professional with people struggling with addiction and dependence is that they often don't know that people truly understand them. And we know that it is difficult to show care and concern because sometimes we have to say no to people. For those of you who are in the behavioral health field, for example, in medication-assisted treatment, you might not be able to give people the prescription that they want. And so we often do have uncomfortable discussions with patients around the amount of MAT that they should be prescribed, pain medication, other things that they need, other things that they ask for that are not possible or not possible right now without a prior auth or something else. And those are all opportunities, unfortunately, for the door to get closed again just when it's been opened and people are walking through. And there are times when we can't say yes to everything people ask for, but we can at least talk through why we can't say yes and what are some possible next steps to get people what they need. And then the closure of that one session and other sessions. Sometimes it's not always possible to end on a great note, but we try to end on a positive note. We try to end on a note where we let people know we are sorry if we couldn't give them everything that they wanted, or we could not arrange a service because of a delay in that service or something else, or more steps that need to be taken in the process. But we will work on those at a later date. And we try to keep that door open and continue to show empathy and have a different type of closure. And there are clearly ethical limits to this. We know that, for example, one of the things that my team constantly talks about is just how hard it is to see people deteriorating or saying no, or sometimes just continuing to engage in certain behaviors or continually being in crisis. And again, we face that balance of let's work on this crisis today, but you have been in crisis a lot lately, and I really want to work on getting you out of crisis. Let's also work on this. Can we start that process today? It means that sometimes we offer something or say something that does not go over well, and we've got to be quick on our feet and offer the next possible service or offer a next step as a way to engage in that service. And so being quick on your feet to not lose people and not have either a showdown or an engagement with someone that does not result in them getting their needs met, we have to keep trying to work on other things. Again, we know that we are offering a compassionate approach to keep people alive. It doesn't always mean that they will be well right now, but we hope that they will be another day if we continue to offer more services. I think about people that I have seen that come in 10 different times, say no or refuse to talk to anyone, and then suddenly at the end of the day, somebody asked me if I wanted this in the morning. I do now. And we're faced with, well, we close in 41 minutes, but we're still going to begin working on that, because sometimes it takes that type of approach for people to ask for help or say yes. It also means that sometimes we have to say no to people. And again, we try to do that with empathy and warmth. In our personal lives, if we are caring for or have family members or partners or peers struggling, what do we do to help them? Again, much like service providers, we provide what we can when it's possible to do so. We don't have to or can't always offer everything that a loved one wants. We want to support people's goals for their care. We want to try to get people the help they need. We want to take a similar approach as we do with service providers, that any kind of change is good. Small incremental goals are necessary to help people and to get people to feel like they've accomplished something and can go on to the next step. We know that sometimes, unfortunately, we have to say no to helping people. We get calls all the time from parents. I know that they are calling from your facility. They are calling me and asking for money, and I've offered an ID check instead of money. These are the practical struggles of people serving and caring for those facing addiction and dependence. And sometimes a no has to be the answer that is given, no matter how difficult it is. But we say it with kindness and love, and we offer something else. We know that each event stands on its own. I talk to parents who had to say no 5 times. The 6th time they were moved to say yes, and that worked out. Maybe it didn't in the past. So we take each event as it comes. We try to offer people what they ask for with compassion and love, but we can't always give everything. But we also know the past is changeable. Sometimes we know that people are at that motivational or change moment. And again, we can unlock more doors by looking at the rest of the services. So let's briefly talk about the rest of the harm reduction continuum. It involves on-site medical care, wound care, hepatitis C, HIV, behavioral health care, warm handoffs. We cannot provide everything in our shop despite having 9 medical providers. We do have to hand people off to acute care and other types of specialty care. And we also take referrals from acute care and other settings, including corrections. We know that behavioral health partnerships are critical, both with the publicly funded behavioral health system, but also with others. And then we know that homeless outreach and housing partnerships and provision of services are critical, including low barrier housing, or what in many jurisdictions people refer to as wet housing, where you can be intoxicated or be using alcohol actively, not in the facility, but before coming in. We know that there are also in the substance use realm and housing realm, there is homeless respite for people who are intoxicated using opioids and stimulants and psychostimulants as well. And that is a critical way to engage people who would not be getting help elsewhere. And similarly, we provide services. Drop-in centers, access points that offer hygiene kits and other services, public restrooms, and diversion programs. Just briefly, first response and overdose reversal reporting. We, in the harm reduction services, reverse up to 15 overdoses a week, depending on the season and locations. And harm reduction, we have been reporting into ODMAP for a few years through the DIVIC. We take seriously our role as public health partners and in reversing people and in documenting those reversals and documenting community-based reversals. Back to the specialty medical care. This is an example, again, of meeting people and walking with them by bringing medical care to them. We bring wound care, we bring mobile HIV care and hepatitis C treatment. Not all of it. We try to get people in the building for more ongoing care. We bring mobile MAT to the street. And wound care provided in the building, we see more patients. Wound care provided on the street by parking somewhere and then going out on backpack allows us to find people that would not come into the building or even the vehicle for wound care. A lower number of people sometimes, but people with critical infections and at high risk for limb loss or with existing limb loss. We work with public health nursing through the health department to find people, engage them in surveillance, offer hepatitis A vaccines, etc. In fact, with the outbreak of hepatitis A the summer prior to this past summer, within 2.5 months of public restrooms and the health department coming out to do hepatitis A vaccines, we had brought hepatitis A infection rates back to pre-outbreak levels. Homeless outreach. Oh, and just back to that, along with medical care is medical case management. For example, HIV-related medical case management, hepatitis C-related medical case management, and harm reduction case management, where we actually see lower rates of signing out of hospitals or other settings when a harm reduction case manager from the harm reduction service program that we have is engaged in their care. Homeless outreach is a way to find people who are unsheltered chronically, but who also use drugs and get them into the continuum. There is a lot of great homeless outreach work around the country, getting people with mental health conditions and chronic homelessness into coordinated entry in the housing system, less so with people with chronic substance use issues. Philadelphia is proud to have not only a Housing First program, but over the last few years, 3 opioid-related Housing First teams through Pathways to Housing PA, specifically housing people with chronic homelessness who have chronic substance use, primarily opioids, but other substances. And we know that we use that to link people to care. And here is our prior to be filled, one of our 2 respites. Now we have a lot of hoarding going on, so it doesn't quite look the same, but we do have people come to see them. I don't need to talk about fentanyl testing. You all do that. Many of you do that. Our biggest change in the fentanyl education and awareness and outreach and fentanyl test strip distribution over the last few years is that we are specifically not just targeting people who use opioids, who choose opioids. We know that at the syringe service program and other settings, we will find people whose primary drug of choice is an opioid. First heroin, now fentanyl, but also other prescription opioids. But we know that increasingly people who use cocaine, K2, PCP, methamphetamines are at high risk of their substances being adulterated with fentanyl and being at high risk for overdose. And we often find people in the outreach process that say, I had no idea I was getting fentanyl. It's a critical way to keep other people alive. The access points are also a critical way. You offer a hot meal, you offer showers, you offer hygiene kits, you offer food, you offer immunizations and art programs even, and a mail program that now has over 3,000 people receiving mail at our shop, for example. It's a good way to get people in for care and then realize they won't be judged so they can be themselves, and then ask for more help, including substance use treatment and medical care. And then the reentry programs. Many of you know about diversion programs. We are really excited that we not only do a classic diversion program, we do social referrals, and more recently through a reentry program that we had funded through ONDCP via Kugli, thank you. We have been able to include case management that specifically works on addressing the legal issues. Let us take your legal issues right to the judge, right to adult probation and parole, help get you SSI or in employment and substance use treatment, and try to get you out of the legal system. And so these are the various approaches in the harm reduction continuum that coexist together and get people that we serve and love who are struggling with addiction and dependence into care. Maybe not always day one, but we offer day one. We don't offer so aggressively that they say no day one, but we offer all comers, and we meet people and serve them where they are and as they are. Okay, I'm looking at some of the poll questions. So I don't know if you want to ask some questions. I'm just looking at this poll question. The top 3 harm reduction methods people want more resources or attention to are MAT. Yes, and it is harm reduction. I would also, again, argue that MAT out of a harm reduction program is an additional way to innovate and reach even more people. Syringe services, as you know, there is a technical policy person in the state of Pennsylvania through the health department, Roseanne Scotti, who is working with different jurisdictions to help people, identify the need for harm reduction services. And there's a way to reach out to the CDC. And we'll also give a shout out to Dr. Jean Bennett at SAMHSA Region 3, who has also been facilitating a collaborative of jurisdictions and harm reduction providers and those interested in getting SAMHSA and CDC guidance around syringe service programs. Naloxone leave behind. Cannot state how critical it is for people to leave behind naloxone, not only in the case of traditional first response, but when you are working in substance use treatment or other, and drop-in centers. I'm so excited that people want more support around drop-in centers and building brick and mortar services, or bringing them into your existing services to bring in people who use drugs to help them get the help they need. Yes, I can.
Thank you, Silvana. What a great presentation. We learned so much. Can you hear me okay? Great. I'm gonna hide this poll, and I know a few didn't have a chance to answer the first one, so I'm gonna jump back to get that. Bear with me. So I'll be jumping back to the lobby to give you a chance to answer that first poll question that was popped in, and then I popped out too fast. And I'm also going to start the Q&A. I have collected a few questions here that came in. First of all, how do we expand access to funding for harm reduction efforts across Pennsylvania? This is a vital service that is provided to a very vulnerable population. Funding is needed to do this important work. So the first question there, how do we expand access to funding for harm reduction efforts across Pennsylvania?
The state Department of Health with DDAP support and Vital Strategies is funding a role in the Department of Health specifically to help people start harm reduction or expand harm reduction. Roseanne Scotti. So that is one way. Please reach out to her. My understanding is she's going across the state to help people. The Pitt Peru TAC also offers TA, and so do we. We actually help programs. In terms of funding, there are very limited foundations that fund harm reduction and syringe service programs. Examples of funders include AIDS United, and I'm not going to remember Drug Policy Alliance, and I'm not going to remember the others right now, but I'm sure we can get a list out to people. And certainly people can reach out to me. So that's one way. That's still very limited. The other way is the wraparound services. So we started our syringe service program in 1992 formally through an executive order, and we did not get funding for that right away. We are actually, there's the early intervention bucket in the DDAP levels of ASAM levels of care. So there's early intervention funding is one potential possibility, but not for supplies. Depending on the, not for supplies. There is also a way to reach out to the CDC, and there's guidance around applying, but people apply for the wraparound services. So an example is HIV testing is something that we get funding from the local health department. There's medical case management, or I don't know if CRCS is an intervention anymore, or the artist intervention. Those are just examples of other funding pots that can place people into harm reduction programs that you can pay for staff with, for example. Another one is HIV and PrEP navigation out of a syringe service or other harm reduction services. So oftentimes we're layering other services, and that's critical too, because we don't want to just have people on a line getting harm reduction supplies. Good as that is, we want to also offer them other services, and we need people to broker referral to other services. So those are the critical ways.
Thank you for that. I'm going to bring up the next question here, and there's also a poll question. Everybody look to the left. I've opened up the third poll question, and so the next question from the Q&A: How have you seen a change
a lot more people
in the mobile
out on the
care
street.
recipients within the pandemic?
They're either afraid to go elsewhere, they're not able to return home. We see a lot more people outside, and we have had to, unfortunately, we've capped our facilities running. A lot of the services are now outside from a door or from a table to keep infection control measures during COVID, but we still find that very many people come. The mobile syringe service programs were not affected by COVID. We still had people coming to them. And one of the things that we really ramped up is secondary education and support. We've had to alter services by telemed is wonderful. A lot of our folks are unsheltered. That may not be the case in some of your jurisdictions, but we've had to offer additional support, engaging people with phones or iPads in and around our buildings and at mobile sites, and offered that type of support. But we've definitely seen people's access to medical and other services be impacted. Wound care numbers, wound care treatment outside and in the building, when we brought wound care back into the building, the numbers have gone up drastically of patients seeking wound care treatment, because what many of us did early on in the pandemic was counsel people not to go to overcrowded hospitals or facilities that were testing for COVID or that would not see them. Now we're seeing that we have to provide a lot more care in the medical settings in the community.
Mm-hmm. 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 That makes sense. Thank you for that. Looks like we have time for a couple more. Are there places and dealers where people are finding
no? I think that depends on your jurisdictions, and it depends on parts of the city. So, for example, between 2013 and today, it's almost impossible to find heroin in the city, except in certain parts. It's almost all fentanyl now. We are seeing, I'm not sure how accurate this is, but what we feel we are seeing is a change in the cocaine supply, with some of it being replaced with methamphetamine. So there's certainly people seeking it out, but a lot of people that are getting it without realizing it. We are seeing that a lot more of the kind of street corner activity involves all substances, and it involves, a mix of substances that may be, we know that a lot of people will have 4, 5, 6 substances in their system at any given time. What we're hearing from people, and what it looks like, is that um, where a purchase might have 1 or 2 substances, now they often, depending on where they are, might have also 3, 4, 5 substances. So people are getting a lot at once. Sometimes it is what they are asking for if they know where to go, and sometimes it's not. And people are, a lot of people are at the mercy of what is being put out there.
Thank you. Thank you. Do you provide harm reduction
We do,
resources to treatment
and I'm
providers
sure you
to
can
share
imagine
with
that's a tough
patients who
sell with
might
some
be
treatment
considering
providers,
walking out of treatment?
or with assessment centers. I believe it was Chester County, but I can't remember exactly, a few years ago, that told us that at assessment centers, let's say one of the counties in our area, was giving out Narcan, for example, at assessment centers in case people walked away. So I don't quote me on which one, but there's a lot to be said for doing Narcan distribution and other harm reduction education for people that might walk away from treatment during the assessment process. We know that sometimes waits are several hours and people do walk out, and they walk out in withdrawal. We also know, it's no secret that even people in substance treatment, for example, for opioids, are still dabbling in other substances and testing positive. We know that, a harm reduction approach also means that if someone is using other substances even regularly, we don't want them to overdose and do badly. So we will keep them in treatment and slowly try to work on the other substance use. So there's a lot to be said for including harm reduction in substance use treatment, induction, and engagement, knowing that people will still be doing other things and that they can always, unfortunately, walk away.
I think at this time, I want to thank you so much. I hear an echo from the other presentation. So I think
Thank
we're
you.
getting back to the plenary session at 1:45. So I'm going to let
Goodbye.
everybody have
Thank
a
you for all that
couple-minute
you
break.
do.
Thank you so much. It's been a pleasure. Take care, everyone.